You have the Angelas with you this morning, Angela Jensen and my esteemed, incredible partner, Angela Franklin. And we are part of the Older Adult Behavioral Health Initiative representing Josephine County. This is an Oregon initiative for those of you that may not be joining us from Oregon. We want to remind you of training etiquette and your CEU details because we know that's very important. Please put your microphones on mute. If you're not on mute, we will mute you. Just know we will give you the slides and all the information that comes along with this training. You will receive that in the next week to 2 weeks, okay? To claim your CEUs for today's trainings, there is a couple of steps that you need to follow. You'll be receiving some surveys. We kindly ask that you fill those out. We partner with the Portland State University's Institute on Aging, so do not discard that if you see something from Portland State University. That is one step to getting your CEUs. So we need you to give us that feedback. You're going to receive follow-up emails and just please put us in your address book, your contact list, so you don't inadvertently dump us. These are not trash emails. These contain info that you will need. Okay, and as a quick introduction to who we are and why we're here, we want you to know about the Oregon Older Adult Behavioral Health Initiative. We're not going to read this slide to you. There is a website that shows you everything that this initiative is doing around the state. If you're not from Jackson or Josephine counties, you can look up who your specialist is for your county. Please reach out to them, especially if you're doing any work in the world of older adults. Angela,
okay,
we are just about ready to kick it off. I just need to give a quick shout out to Dr. Shaw, the medical director of Providence's Doctors Clinic. Thank you for joining us today, Dr. Shaw. We appreciate you giving up some of your time. We want to recognize the Jackson and Josephine County APD staff and our options partners, and Melissa McGuire of Asante Health Medford, who requested this training, and that is why we are able to bring it to you today. So I will turn the microphone over to my esteemed colleague and to our trainer, Nirmala. Thank you all.
Yeah. Hi, Angela. Angela Franklin, you're going to do the poll questions?
Yeah, we wanted to actually introduce you really quick.
Sure.
And you can put the poll questions up while we're doing the introduction, Angela Jensen. So Nirmala Dhar is a licensed clinical social worker with a master's in social work from the Brown School of Social Work, Washington University, St. Louis, Missouri, and also Bombay University in India. She's mission-driven and has a passion to work with the most vulnerable clients, often with cross-sector complex care needs. Nirmala has worked for 36 years in all aspects and programs of behavioral health in the public sector in Missouri, New Jersey, and Oregon. She's a senior policy analyst and older adult behavioral health service coordinator for Oregon's Health Authority Health Systems Division. So in this position, she's the Older Adult Behavioral Health Initiative Project Director, the PASSAR Level 2 Coordinator, and Subject Matter Expert for the OHA. She's the Project ECHO Geriatric Behavioral Health Champion at OHA and helped create the first nursing home ECHO on the West Coast in 2018. So prior to this position, she's worked for Clackamas County Behavioral Health for 18 years. This includes 10 years as the geriatric mental health specialist for the county, and she has provided trainings on a variety of topics over the past 20 years, locally and nationally. She lives in Lake Oswego with her husband, Sanjay, and we are really happy to have you give this training, part one of a two-part series.
Thank you to both the Angelas and to Janine, who is your peer from Jackson County, who is not here. So thank you. I would really love to know just who in the audience, kind of your baseline knowledge. So I have these two questions. If you can please, it's a yes and no. If you can take maybe 10 seconds to complete it, and then I will ask Angela Jensen to display the answers. Thank you.
We've got 92% participation. So would
Okay.
you like us to?
Yes, please, please
kick it off?
go and do that. Yes.
Okay. Let's see if this will display. There we go.
Oh, there it is. So thank you. So 70%, so the majority of you have not attended a training on this subject in the last 18 months. And 3/4 of you don't routinely screen your patients or clients for traumatic brain injury. Thank you very much. These questions are germane to my presentation today, so I wanted to know, kind of get a baseline feel. So thank you again for inviting me. Initially, it was Melissa, whom I met several months ago now in April at an ethics conference where we connected. So thank you for inviting me, and for both the Angelas for putting this training on and hosting it. My topic is divided into 2 parts because with 1 hour, I'm not able to cover everything. So this first part is really what should you know about traumatic brain injury, all of you who are here today. Next slide. And very quickly, my learning objectives are: you will understand the definition, you will understand assessment, mainly like severity and impact on the person's functioning and life, and the importance of screening. And unfortunately, I won't have time for resources, like what are your local or Oregon resources, and I'm going to leave it up to the 3 older adult behavioral health specialists to perhaps put together an archive, curate a list of brain injury or brain health resources to send out to all of you. Next slide. So I want to start with this. Does the name Phineas Gage ring a bell? I'm hoping it does, because he is neuroscience's most famous patient. So keep that name in mind, Phineas Gage. Next slide. So who was Phineas Gage? He's often referred to as the man who began neuroscience. He was a 25-year-old foreman in the 1800s in Pennsylvania, and he was on a work team which laid down railway lines. He was going, his job on that particular day, on September 13th, was to lay dynamite, and so that they would clear the area to lay the rail line. Unfortunately, the dynamite went off early, and an iron rod was driven through his skull, destroying much of the front part of his brain, the frontal lobe. Miraculously, he actually survived. However, his personality and his behavior was so changed as a result of this accident to his frontal lobe, the damage that resulted from the iron rod, that many of his friends and co-workers described him as almost a different person. That means he had such a profound change in his personality, and he was never the same again. After the accident, he was unable to keep his job as a foreman. He just couldn't work on the job. He kind of did odd jobs here and there, including joining the circus, because he was kind of an oddity. And eventually his functioning got so worse that he had to move to San Francisco to live with his mother and his sister, where he died 12 years after his injury at a very young age of 37 years old. His brother eventually donated his skull and the tamping rod to Harvard University School of Medicine. And by the way, you can still see his skull and the tamping rod at Harvard. So keep in mind Phineas Gage as we talk. What kind of traumatic brain injury did he suffer? Which part of the brain was affected? What was the severity and what was the impact? Next slide. Numbers really paint a real clear picture. In 2021, which is the data, the latest data, 190 Americans die from TBI-related injuries every day. 190 every day. 223,000 TBI-related hospitalizations. A 250,000. And then in 2019, about 15% of all high school students self-reported one or more sports or recreation-related concussions in the preceding 12 months or 1 year. So think about these numbers for a minute. 190,000 die every day. 250,000 TBI-related hospitalization. And look at that. 1 in 6 high school students report some kind of concussion to their head in the previous 12 months. Next slide. So what are the most common types of traumatic brain injuries? Remember, I talked about Phineas Gage. His was rather dramatic. But, the others are pretty mundane. No, not pretty mundane. Some of them are really mundane. Some of them are, should raise an alarm. So the most common reasons are a fall, firearm-related injury, motor vehicle crash, and assault, most often intimate partner assault. Did you know falls lead to nearly half of TBI-related hospital stays? Firearm-related suicide is the most common cause of TBI, surpassing motor vehicle accidents about 2 years ago. And then I already told you that auto accidents and intimate partner violence. Now, imagine the groups that you need to be aware of in your work to ask and screen for TBI. It could be someone. It could be a female, a woman who is in an intimate part, in an assaultive relationship. Have you ever thought of asking about traumatic brain injury? Because look at it, it's one of the most common reasons for a TBI. Next slide. I already emphasized that suicide is now the leading cause of TBI-related deaths. It surpassed unintentional motor vehicle accidents. So it is really firearm injury was the underlying mechanism for these TBI-related suicides. So almost 97. So these are people who intended to die by lethal means from suicide, but did not. So they survived it. But now they have this kind of traumatic brain injury. So therefore, and I know Angela Franklin, one of the OABHIs for Joliet County, is also part-time your suicide prevention coordinator. Reducing access to lethal means among persons at risk for suicide is a very important approach to creating protective environments. How many of you ask about lethal means? How many of you ask routinely, do you have a gun in the home? And it may not even be suicide related. There could be young children in the family. There could be, there's a risk for intimate partner violence. So absolutely reducing lethal means is one way to increase resilience and build protective environments. Next slide. So how many people are affected and who's most at risk? Did you know People age 75 years and older had the highest number and rate for TBI-related hospital stays. Remember, I said 250,000 people going to the hospital. Out of that, the majority are age 75 or older. So not only for hospitalization, but also for deaths. This group accounts for 32% of TBI-related hospitalizations and 28, more than a quarter of all those TBI deaths. Remember I said 190 a day are older adults. Now, is that news to you? That it is the leading cause of traumatic brain injury for older adults is a fall. And it's deadly for older adults. So older adults are at high risk. Men are nearly 2 times more likely to be hospitalized and 3 times more likely to die from a traumatic brain injury than women. I mean, 3 times more likely. That is statistically way, way, way significant. Children, that means under the age 17 and below, obviously less in numbers, but for purposes of today, I'd like you to think about older adults as a high-risk group and men as a high-risk group for traumatic brain injury. Not that you ignore other groups. Next slide. So here are groups I'm going to talk a little bit more because we all are on this mission for eradicating disparities. So here are groups which are at greater risk of dying from TBI or from its long-term sequelae or problems. Racial and ethnic minorities, service members and veterans, people who experience homelessness, people who are in correctional and detention facilities. I've already mentioned 3 or 4 times survivors of intimate partner violence, and people living in rural areas. Just because the last point, there's less access to kind of really emergency services, and also that there is a higher prevalence of gun ownership in rural households. Next slide. So here is the definition. What is a traumatic brain injury? A traumatic brain injury is caused by a bump, a blow, or a jolt to the head, or a penetrating head injury that disrupts the function of the brain. A penetrating head injury could be a gunshot wound, like the bullet going through your head, or what Phineas Gage experienced. Remember, an iron rod went through the front of his brain and came out from the back. That's a penetrating head injury, but it can be a bump, blow, jolt. It is caused by an external force to the head. Think about sports. Remember, high school students, 1 in 6 reported having some kind of a concussion 12 months prior to that survey. Where would they get a bump, blow, or a jolt? The severity of injury to the brain ranges from mild and actually undetectable to severe and life-threatening. And not all blows and jolts to the head result in a TBI. But it's better to have it checked out. So a TBI can occur in traffic accidents. I just told you, that's a second leading cause. Now, suicide is the first. Falls, sports injuries, gunshot to the head in the course of military service, and in many other settings, resulting in millions of emergency medical visits annually. And Good news is that this is a modifiable risk factor that we can bring down TBI deaths. Think about the older adults that I talked about. I'm hoping your wheels are turning in your brain. What can I be doing with my older patient or with my older, if you're a case manager, or with my older consumer to prevent falls? Next slide. So here are types of, so now I've given you the definition. Now these are types of head injury. One is called closed head injury, and they're any of this, concussion, coup contra coup, blast, all of them. And we're going to talk about them. And the second one is open head injury. Okay, next slide. So types of brain injury. Closed, what is a closed head injury? The skull and the brain content have not been broken into or through. That means it's still intact in your skull, your brain. Unlike what happened to Phineas Gage. His was not, so closed means your brain is not broken into. Damage occurs due to the blow to the head or jarring movement, which bruises the brain and causes damage to the nerve cells and blood. So there is actually no rupture, there's no big, your head is not wide open, but there's damage that when that jolt or blow happened, your brain responded to the jarring movement by moving in its cavity, the skull, that caused damage. And guess what? Damage can occur in a specific area or throughout the brain. Now, Phineas' damage was all in the front of his brain. Here is an example of a closed head injury or brain injury. Concussion resulting from a crash or a fall. Your brain is not wide open. Your skull didn't crack open, but it has done enough damage. Next slide. The other type is called open head injury. The skull and other protective layers have been penetrated and exposed to damage. Whether you are part of an IED, that explosive device blew up right near your head, or you had a gunshot to your head, or like Phineas Gage, it was an occupational hazard. The pole went through his head. It basically penetrates and exposes, and your brain is exposed to damage. Damage is severe, and the primary injury is usually limited to, one section of the brain. For example, gunshot to the head. So remember, why am I giving you this information? The next time you meet one of your clients and they say they had a traumatic brain injury, my hope is that you'll ask, was it closed or open? But it's very different. Next slide. And then in addition to closed and open, we have primary and secondary. Primary occurs at the time of the incident, such as skull fracture, localized injury, or what we call diffuse axonal injury, widespread damage. So it happens right away because of the jolt bolt, penetrating injury. Now, secondary occurs after the initial injury when the brain tissue swells, resulting in the lack of oxygen to the brain. How many of you know this? She was a wonderful actress, Natasha Richardson. She went skiing one day and she fell and hit her head and didn't really bother, to get it checked out. And she died next day. She was very young, in her 40s. She had a concussion, and what had resulted was all of this swelling in her brain, which cut off her oxygen. She died. So yes, so secondary, sometimes secondary injuries can also be life-threatening. Next slide. So I'm giving you some definitions of, the most common that you all hear about: concussion or contusion, or were you concussed. This is what generally it is: a violent jarring or shaking that results in disturbance to the brain. And it can result in short loss of consciousness. And we are going to look at those categories. It can cause nausea, headaches, vomiting, dizziness, some short-term problems with memory and concentration. So when you talk about asking about concussion, this is what you're referring to. And these are like possible symptoms to ask your client or patient. Next slide. So this is, I'm just giving you a graphic about, what happens in a concussion. Can you see the brain? No, could you just go back? The brain goes forward and back. It kind of hits the back of the skull and the front of the skull without any kind of outward breakage. But it's causing tremendous damage depending on the force of that blow or that jolt. Next slide. I think did we miss one? Okay, next one. Okay, so I just wanted to talk very briefly about this diffuse axonal injury. So what happens is, I remember I told you this rapid acceleration of the head in your skull. And when that happens, this motion can create forces that can destroy axons, nerve endings, which all help, nerve bundles, which all help brain functioning. And that really results in the traumatic brain injury, that kind of force with which your head is moving in your skull rapidly. Next slide. So TBI and concussion, it is sudden movement can cause the brain to bounce around or twist in the skull. It can lead to chemical changes in the brain and then stretching and damaging brain cells. This effect can lead to symptoms that affect how a person thinks, learns, feels, acts, and sleeps, which are all of our cognitive functions, depending on how severe the concussion was. Next slide. So here is how you assess for severity. Mild traumatic brain injury. LOC stands for loss of consciousness, okay? So for mild, you have no loss of consciousness or less than 30 minutes. So it becomes critical for you to ask your patient or your client, did you lose consciousness? Can you remember for how long you were out? Because that tells you the severity. Moderate is 30 minutes to 24 hours that you're out. Blackout. Often you're in a hospital or an ED. And look at severe. It's I need to actually change my apologies. I forgot to change that. It is more than 24 hours to months where you're in a coma. So for you to assess severity, it's really this simple. It's what was the length of time that you were knocked out, that you lost consciousness? Anyone want to tell me, aside from football, which other sport causes knockouts, blackouts? You can just unmute yourself. Someone is saying rugby. Anything else? Soccer?
Boxing.
Boxing, yes.
We had a situation in baseball game where two guys went for the ball and collided, and he had a moderate, probably TBI, but completely lost hearing, passed out, seizure. It was traumatic.
Yeah. So think about this the next time you are asking your client, and trying to assess severity. No loss of consciousness or less than 30 minutes is mild. 30 minutes to 24 hours is moderate. 24 hours to coma is severe. I worked with clients who've been in comas for 3 months from a TBI. can you imagine the severity? So this is an easy classification for you to use to determine severity. Next slide. By the way, this person at the bottom, my citation, Dr. John Corrigan, he is a national expert on traumatic brain injury. Please Google him. He's from the Ohio State University. But this is a nice graphic representation of the continuum of TBI severity, which I just told you, which we just talked about. As you can see, mild, mild is really you're a little bit dazed, confused, very low, less than 30 minutes loss of consciousness, to the most severe is where you're in a coma. Next slide. So it's not just the severity now. Remember I said first ask the question, remember the risk groups, then assess for severity using the three standards I just talked. But in addition to that, there's more. Cumulative effects of multiple TBIs. If you're playing hockey and boxing every week, you're getting hit on your head every week, correct? Or some other high hazard occupation, like veteran soldiers. So cumulative, how many TBIs have you had? What was your age at those injuries? How recent was the last TBI? Is this combined with any other kind of neurological conditions you have, seizure disorders, for example? So not only do you need to assess severity of traumatic brain injury using that scale, but also all of these compound the severity. So absolutely vital questions to ask. Next slide. Here are red flags for histories of TBI likely to have a lasting impact on their functioning. Because ultimately, it's about functioning. How do you live your everyday life in the community with the TBI? The worst, or the worst severity, one moderate or severe TBI in your lifetime. When was your first TBI? So if you have had loss of consciousness before age 20, it will have more of an impact. Multiple or cumulative TBIs, especially if they're close together. Recent injuries, even if they're mild. So all of these should absolutely raise your red flag that, hey, this person's TBI is going to be worse. Their functioning will be worse if they meet any of these red flag criteria. Next slide.
Nirmala, I just want to remind you we're halfway point.
Okay, thank you. So very quickly, I'm not going to spend a ton of time on this because you will get this slide, but really, I want to talk a little bit about the brain so you understand, when we are talking about, which part of the brain gets affected. So I will let you read about the left-right brain on your own, but if you can move to the next slide. So here are brain areas, and each area is associated with some function. So it's made up of 6 parts, and any of these parts can be injured. If you see the red part, their frontal lobe, that was where Phineas Gage got his traumatic brain injury. So the effect of your client's brain injury very much is determined by the location of the injury. Did it happen in the occipital lobe? Did it happen in the frontal lobe? I mean, where was the injury? Sometimes only one area is affected. But in most TBIs, multiple areas are affected. Obviously, the more areas affected, the more severe the injury. So take a look at the brain. This is your brain too, you know. These are the 6 parts of your brain. Next slide. Now look what those 6 parts do. Brain stem, it controls breathing, heart rate, swallowing, sleep, balance, alertness. Cerebellum, coordination, balance, equilibrium, reflex. Imagine one of your clients walking into your room for an intake and they can barely coordinate, their balance is off. He's a young male, possibly a veteran. Boom, you should absolutely think, is this due to a traumatic brain injury? And is the injury in the, at the cerebellum? Frontal lobe, like Phineas Gage. Look at what the frontal lobe injury can do. Or frontal lobe function, sense of place, initiating activities, judgment, emotion, regulation, language, memory, planning, organizing, reasoning, understanding, problem solving. Now keep that in your working memory, in your mind, because I'm going to bring it up. What are the functions of the frontal lobe? We sometimes call them executive functions. And the frontal lobe is called the CEO of your brain, the chief executive officer of your brain. Look at the parietal lobe. Visual attention, touch, movement, integrating senses. Occipital lobes, vision. Temporal lobes, hearing, memory, visual recognition, verbal processing, emotion, all of that. Why am I giving this to you? Because if you are going to be working with your client, it may be good to know which part of his brain was affected. And that is the resultant deficits in functioning. What services and supports do I need to put in place for my client? Next slide. And guess what? The fingerprint of TBI. Remember, all our fingerprints are unique. We can be identified by our fingerprints. Similarly, the fingerprint of TBI is frontal area of the brain injury, including frontal lobes, are the most common areas to be injured as a result of a TBI, regardless of the point of the contact. Because remember, I said your brain moves in your skull cavity, and that's the red part. That's where your executive functions lie, are controlled. So remember, the fingerprint of TBI is frontal lobe injury. And why? Because the frontal lobe is your chief executive officer, and that's where all of those executive functions exist. And what are executive functions? They help us live independent lives in the community. Next slide. Factors that increase the likelihood that there's lasting effect of TBI. We've already talked about the severity of any one TBI. Remember that three-part scale. Cumulative effects, developmental interactions, and recent injuries. So they can make your TBI prognosis worse. Next slide. So mental health and brain, our initiative is about behavioral health. Almost half of adults with TBI who have no pre-injury history of mental health problems develop mental health problems after the TBI. 1/3 of TBI survivors experience emotional problems within 6 months of their injury. And also suicide is very high in this group, prevalence of suicide. Next slide. And here are the psychiatric comorbidities that occur with TBI: depression, suicide, PTSD, substance use, and now we are also particularly calling out opioid use disorder. Next slide. Persons with TBI often experience medical conditions as well as multiple behavioral health disorders after their injury. Common health problems are headaches, fatigue, dizziness, sleep disturbance, balance problems. They may develop a seizure disorder. They may have vision problems like blurred visions. All of that develops as health problems. In addition, they have personality and psychiatric changes, such as apathy, decreased motivation, emotional lability, that means they have wild mood swings, irritability, anxiety, depression, disinhibition, including temper flare-ups, aggression, cursing, just a blowout, lower frustration tolerance, and increased inappropriate sexual and social behavior, all a result of the injury. Next slide. I'm not going to go over each of these slides, but depression and anxiety are common. And it has a detrimental effect on health-related quality of life following traumatic brain injury. So how important it becomes to screen for depression if you are seeing a person with TBI. Because if you're not going to treat the depression, their functioning is not going to improve. Next slide. Post-traumatic stress. PTSD describes a group of symptoms that may develop after you're exposed to actual or threatened death, serious injury, or sexual violence. These events can include combat exposure, domestic violence, sexual and mental abuse. So is there a connection between concussion and PTSD? Can I have both? Of course. You can have concussion and PTSD. You can have both. Some people with concussion will have PTSD, but not everyone. It's not that you have to have PTSD with a concussion, but it's often common. And sometimes, which is the conundrum, symptoms of PTSD and concussion can be very similar and very difficult to tease out and tell apart. All of you clinicians on this training will realize that. Next slide. And I found this wonderful little thing from the Traumatic Brain Injury Center for Excellence. And they're really looking at TBI symptoms, psychological symptoms such as PTSD, and what is the overlap. And why does it make it so difficult? Look at the symptoms of TBI: headaches, dizziness, nausea, sensitivity to light, vision changes, impulsivity. Psychological trauma, high alert, we call that vigilance. Startled response, you're easily startled. Fear, flashbacks, nightmares, guilty feelings, avoidance, feeling numb, having self-destructive behavior. And look at the overlapping symptoms: fatigue, sleep problems, trouble with memory and attention, feeling depressed, anxious, irritable. So often it becomes very difficult for clinicians, like many of you on this call today, on this webinar today, to tease out, hey, what is TBI? What is psychological trauma or PTSD? How do I know which is which, and how do I treat them? Next slide. Substance use. Substance abuse is a risk factor for traumatic brain injury, and traumatic brain injury is a risk factor for developing substance abuse. So what I'm highlighting here is the bi-directional relationship of alcohol and other substances. It can cause traumatic brain injury, and traumatic brain injury can cause substance use problems. Next slide. So there's a tight relationship between substance use and traumatic brain injury. Traumatic brain injury and substance use disorders frequently co-occur. People with histories of alcohol and other drug use are at greater risk for TBIs. Up to 75% of TBIs occurred when individuals were intoxicated. So absolutely assessing for substance use for people your clients, if they have a TBI, is critical for better outcomes or prognosis. Next slide. So there's, just for time, alcohol and risk-taking behavior is well established. Why? Because alcohol disinhibits you. They're strongly associated with risk-taking behaviors, and disinhibition impairs executive function, which is found right here in the front. And so you have this tendency or this proclivity towards taking risk, driving fast, doing other crazy things, which puts you at risk for TBIs, like being aggressive in a bar. All of those are risk-taking behaviors, which are due to you being inebriated. Next slide. So who are at risk? Very quickly, next slide. Veterans. Next slide. The perfect storm is people with chronic pain. Individual TBI face chronic pain, including, I told you, headaches, they feel light sensitivity, all of that. This exposure leads to long-term opioid treatment or misuse and a diagnosis of opioid use disorder. So absolutely checking your patients with chronic pain and TBI. Next slide. Older adults. Falls are the leading cause of hip fractures, traumatic brain injury among Oregon seniors. 1 in 3 older adults in Oregon falls. It is the leading cause of fatal and non-fatal injuries for adults 65 and older. And they suffer from moderate to severe head injuries. While falling is common for all ages, the severity of injury for older adults can result in loss of mobility, independence, and death, which doesn't happen frequently for younger age groups or age cohorts. Next slide. So it's a significant problem for older adults. For persons 65 years and older, TBI is responsible for more than 80,000 emergency department visits a year, out of which 75% of the visits result in them being hospitalized. And I've already said age 75 have the highest rate of TBI-related hospitalization and deaths. So what are we all going to do about that, all of you on this call? How are we going to prevent falls? Have you connected with your local falls prevention coalition? If not, please check in with your older adult behavioral health specialists. Next slide. Homelessness, again, very high. I'm not going to go over it. This was a large study published in the Lancet. It suggests that, that 1 in 2 homeless people, that means more than 50%, experience traumatic brain injury, whether on the streets or they just have a history of that. They already have complex medical issues. Many of them have mental health issues, and now add to it traumatic brain injury. Next slide. So people always ask, what's the difference between traumatic brain injury and acquired brain injury? So remember, traumatic brain injury is by an external force or a penetrating injury. Acquired is a more general term that refers to any acquired, not developmental injury to the brain. TBI is one acquired type of injury. However, not all brain injuries are traumatic brain injury. Next slide. And here I'm giving you a quick list of acquired. I'm not going to go over them, but the broad categories are strokes, bleeding in the brain, lack of oxygen to the brain, infections in the brain, fluid buildup, brain tumors. These are all called acquired brain injuries. So they're not a jolt, blow, or penetrating injury to your head. Next slide. Here are the immediate effects of TBI. We've gone over some of them, but I'm not going to go over them. But just suffices to know there's pain, there's dizziness, there's loss of vision, slurred speech. I mean, dramatic change in functioning. Next slide. And this is how the lived experience looks like. It's a struggle. Learning who is the new you. coming to terms with the loss of your old life, grief and loss of purpose and meaning. You can no longer do what you did before. Admitting that you may need help for the rest of your life. Trying to figure out who is the new me. How do I create this new identity? And stubbornly thinking that life can continue the way it was before. Those are the everyday struggles of someone with a lived experience. How much empathy and compassion do you communicate to your patient or client with TBI if this is what they're experiencing? Next slide. I'm going to skip this. You will get my slide decks. I'm just giving you again, some of the core changes that happen. Next slide. So screening is important. TBI is often an invisible diagnosis. Some individuals may not even know that what they had was a TBI. And documentation is very hard to find because nobody's asking the question. Next slide. So screening becomes important. Here is a very simple 4-question screener. Have you ever been hospitalized or treated in an ER following a head or neck injury? Have you ever been knocked out or unconscious following an accident or any other injury, including sports injury? Have you ever injured your head or neck in a car accident or from another moving vehicle accident? By the way, skateboards are moving vehicle, okay? Have you ever injured your head or neck in a fight or a fall? A yes answer to any question will indicate a formal traumatic brain injury assessment. This is easy to incorporate into your intake questionnaire. Next slide. I have asked Angela to send y'all separately the Ohio State University Traumatic Brain Injury Identification Method, short form OSU TBI ID, which is a standardized, short, structured interview designed to elicit a rich lifetime history of traumatic brain injury. You will get that separately. We do not have time to go over it, but there are links where you can actually go and do a self-paced study free with CEUs. Next slide. So there are a number of key messages. I'm not going to go over all of them, but some of the highlights: TBI vary greatly in severity and there's tremendous variability in terms of its impact on cognition and emotion. The fingerprint of TBI, I've already told you, is the frontal area of the brain. Behavioral health professionals do not identify TBI among their patients and clients. The consequences of TBI necessitate screening during any behavioral health treatment. Next slide. I've given you some resources here. I would certainly ask you to check them out. And next slide. Very quickly, a reflection, please put in the chat. As a result of attending this webinar today, what is something that you knew that you learned? Many of you said that you had not attended a training in the last 18 months. And what is one change you will make right away in your social work practice or whatever other discipline you are going back to your work? What is one change you will make in your practice? Please take maybe 2 minutes to put something in the chat, and I will ask both the Angelas later to read them out. Next slide. And this is really my thank you with my email address. And I want to again tell you to reach out to your Southern Oregon OABHI team, whether you want more trainings, whether you want to know more about falls and falls prevention, any of those topics. And your team here are both the Angelas, whom you've already met today. They serve Josephine County, and then Janine Greenwell is with Jackson County. Thank you for inviting me. I really appreciate this so much. Angela, if you can just remove my slide deck, I'd love to see the gallery of faces. And we have about 7 minutes for any kind of interaction. But if there's anything in chat to my questions, if you either of the Angelas want to read it, I would really appreciate that.
Thank you, Nirmala. Always enlightening when we get to spend an hour with you, an hour or more, because thankfully we have part 2 coming up on December 5th. So please mark your calendars for that. And we're just going to need to give people a little bit of time to type. And if anyone has any questions about what you've heard or thoughts, why don't you raise your hand under your reactions tab, and we will do our best to keep scanning the gallery. I have a question about addictions and TBIs. You did call out the substance use addictions. I'm wondering about the nicotine. And we know that there are high numbers of smokers among our SPMI population. And just anecdotally, I've noted with TBIs as well. Is there anything that you can help us with on that piece? Because I know quite a lot of people want to go in and address the nicotine or substance use addiction. What's the primary focus when you're working behaviorally with someone with a TBI, a known TBI?
Someone with a known TBI, you need to do co-occurring treatment. So you need to work on the TBI portion of the person's presentation, whether it is physical therapy, occupational therapy, speech therapy, all of that, or helping them make accommodations to losses that they've experienced because of deficits in the brain. And it's absolutely important to also work on their mental health diagnoses, which frequently co-occur, whether it's substance use, depression, anxiety, PTSD, because if you are not, then you're not treating the whole person. Remember, we have all moved towards integrated whole person care. You just can't treat one small portion of your presentation and just think the others will just magically go away. If your client with TBI presented to you with diabetes, you would at once also refer them to a primary care doctor to get his diabetes taken care of. We should be doing the same for depression, anxiety, PTSD, substance use. That I showed you frequently, a high percentage co-occur with TBI, whether post injury or prior to injury.
Thank you
But
for the reminder.
Tobacco, just your question on tobacco, I haven't seen any literature on tobacco being a risk factor for TBI. It's a risk factor for cardiovascular disease and death. But alcohol use and other substances are actually a risk factor for traumatic brain injury. And I mean just regular cigarettes. If you're smoking, other substances, that puts you at risk. But if you're just smoking cigarettes, then it puts you at a whole ton of other other risks, health risks, but not for TBI. I'm, by the way, a huge proponent of tobacco cessation for people with serious mental illness. I'd love to come back one day and talk about that. So
I'm sure we could pack that training. Tons of people want to figure that one out. Do we have any questions for Nirmala? We're just at time, folks. If there's a burning question or issue that surfaces for you later, please reach out to Angela Franklin, myself, or if you're a Jackson County attendee, please reach out to Janine Greenwell. We are more than happy to put you in touch with Nirmala or answer whatever we can in the moment. Okay, we're going to have to cut you loose now. As always, it's been a pleasure. And if you haven't registered for part 2, look at me fancying it up. Part 2, December 5th. 9 to 10, that one also comes with CEUs. And of course, you'll be getting all of the materials that Nirmala referenced in today's training. If we have no other questions from the gallery, we will bid you farewell. Be happy, be safe. We hope to see you in a week.